Great, thank you very much. My friend Astrobal taught me 3 words: bon dia, brigado, and caipirinha. So I'm going to use all 3 today. So thank you for allowing me to share with you some of my thoughts about this very important topic, which is about pain control. It's important to remember that most of what your patients are going to remember about the surgery is going to be the post-operative pain. And that period of pain control is very important. So let me just outline briefly what's going on in the United States. And I really enjoyed the last speaker's lecture talking about the Brazilian experience with anesthesia. So in the United States, we're on mark for getting about 60,000 opiate-related overdose deaths this year. And this has been a major problem. If you read the news, you'll hear about the escalation in terms of opiate prescriptions as well as deaths. Now, this has led to a wave, a movement within our country where medical doctors are being caught into this and being blamed for some degree of prescribing too many opiate drugs. Now, Florida is a unique place. Miami, Florida is unique because if you look, for example, in other states, 60% of all of Kentucky's prescriptions are from Florida. This is a real issue. In fact, at one point, Broward County, Florida, which is where Fort Lauderdale is, was responsible for 50% of all the narcotics dispensed in the entire country. So this is a real issue for us. It's ground zero, and you can see this is just one image. And if you've been to Florida, you'll see these pain clinics inside of strip malls. And these pain clinics, you'll see in the morning, people lined up, hundreds of people lined up outside waiting to buy narcotic prescriptions. And there's a doctor there. Many of them have gone to jail who would just write tens of thousands of prescriptions a month. Really a big problem inside of Florida. And it's gotten better in Florida, but it's gotten worse in other parts of the country. And one of the discussions is that this is a gateway drug, that we as doctors prescribe a narcotic, maybe a Percocet or a codeine or a Vicodin, and then that person eventually goes on to become addicted and starts using heroin. So I don't know if this is entirely true or not, but certainly surgeons and doctors are being accused of this. And if you look at this, in the US we have about 70 million surgical patients a year. Orthopedic surgeons are the 3rd largest prescriber of narcotics in our country. Now, I'm a neurosurgeon, and if there were more neurosurgeons, I would bet we would be number 2 or number 4, because we have patients that undergo very painful operations, as we heard the first 2 speakers talk about. Now, many patients that begin with narcotics, if they're young enough, they can become addicted to them. This shows a map of the United States showing the number of prescriptions per capita. So you can see the darker areas. Florida has changed a lot. We cleaned things up about 5 years ago. But you can see this area we call the Rust Belt. This is also where the economic aspects of America have been less vibrant. That is, it's less economically viable in this portion of the country. And you can see this is how we can see that there's a lot more prescriptions there. And this is the death rate. So this is the overdose death rate. So there is some geographical link between doctors prescribing a lot of narcotics and people dying of opiate deaths. Now, this doesn't mean that we are the cause of all this, but there are some other factors, of course, related to this, and I think it's important to understand the optics on this. So if you look at our national organizations, whether it be AAOS, the American College of Surgeons, the Joint Commission, which certifies our hospitals, every one of these organizations, and now the AANS, the American Association of Neurosurgeons, has had to issue statements and responses to this opiate crisis. And if you watch the news, you'll hear President Trump talk about this regularly, that this is a real danger for America. So we saw this the last speaker give this exact same slide. It's a great slide talking about nociception. Now, for the neurosurgeons in the room, you're probably aware that one of the origins of our specialty was pain. If you look back 70 years, the root of neurosurgery, a big piece of it was the management of pain, whether it was neurolysis or neurectomy or cordotomy, and that's part of our DNA. That's part of our evolutionary origin. So neurosurgeons, we understand that there are many aspects to pain and what we feel as pain, meaning nociception. And controlling pain can happen centrally, at the spinal level, or more peripherally. And there are many ways to do this. And I don't know, Dr. Patella, is there a pain section or a pain meeting of neurosurgeons in Brazil? There's a pain group, right? People that just do functional neurosurgery and pain, right? And it's smaller, but it's very important for what we do. And of course, as spine surgeons, pain is part of what we do because spine surgery is one of the top 3 most painful type of operations that are done. Now, I've gotten very interested in the concept of the local control of pain. You can understand that if you control the pain at the level of the brain, that's very effective, but there are many, many side effects of that, like sedation, like nausea, right? But if you can control pain at its source, peripherally, surgical pain controlled peripherally, that's better. And the last speaker did a great job talking about how that can be done from the anesthesiologist's perspective. I'm going to give you the surgeon's perspective and focus on this, which is local anesthetics. Now, if you go see your dentist and you have something done on your tooth, that can be very painful. But usually the dentist will just inject the one little area and your mouth will be numb and you can have a very painful procedure and walk out of the office. And they almost never have a problem with that, right? But we as spine surgeons are always trying to manage postoperative pain. And we're giving all these medications in an effort to do this. So it's important for you to understand all the different type of local anesthetics that are being used today. Now, the last speaker showed these two papers. Actually, I wrote them about the cervical and lumbar use of OnCue Pumps. So OnCue Pump is a elastomeric device. It looks like a ball, about this big, right? And there's different sizes. And what happens is during the surgery, your nurse or your tech will fill this ball, not with air, but with lidocaine or marcaine, and it will expand like a ball. And then over time, that ball will shrink in size and will inject through a catheter like this into the muscle or wherever you decide to put this, the local anesthetic being distributed over many, many days. And I wrote two papers on this, both showing very effective improvements in pain control with cervical as well as lumbar surgery. The problem with this was that I would get a call every single night at 1 a.m. from the nurse, and the nurse would say, "You have to come to the hospital immediately." I said, "What?" They're like, "No, just get in your car and come down and see the patient." So I'd come down, and the patient would have all this clear fluid all over the bed. And so you see your patient's leaking spinal fluid post-op day 0. I said, no. This is this lidocaine. It's coming out because it's being injected, and I have to explain this over and over and over again. And of course, for the nurse at night, 1 in the morning is noon, right? So for them, they're wide awake. They're like, "Yeah, just come in," right? But this was a real problem for us. So what happened was that there was a drug that was released in 2014 in the US called Xpearl. This changed everything about what we do. And Xpearl is a very amazing kind of drug, and I'll explain it to you and what it can do. I don't think you have this in Brazil yet, but it will be coming soon. So Xpearl is a drug that's delivered in a micelle. So I'm going to take you back to your days in college when you learned organic chemistry. This is the key. The micelle is a small liposome, so it's like a fat globule. They're actually very hard to manufacture. It's microscopic. And on the inside of this is the drug. On the outside is the world, right? And so these are microscopic little globules that you inject, but it just looks like liquid. So this is a paper that shows the results at Thomas Jefferson University, and you can see cervical and lumbar surgery that if you inject this, that you get a big reduction in the amount of narcotics being utilized, right? So it's very effective. But here's the important part of this. Look at the size of the error bars, right? Look at the size of that error bar. I always tell people that spine surgery is very difficult. And one of the problems with spine surgery is this, which is the variability in outcome between patients. And so this paper actually showed that it's unclear if there's a statistically significant difference, even though you can clearly see that there's a major reduction in narcotic use. And what we call this is Astrobal will talk about this in statistics, right? This is an underpowered study that definitely patients have better pain control, but the variability between one patient and the next is so big, and you know this. You can do a tiny surgery on someone, and they're in the hospital for a week. You can do a giant surgery on another person and they leave in 3 days. So spine surgery is very difficult in this way. So I've been showing this slide for a very long time. This is about the morbidity of surgery. So people come in, they have some kind of event, and then they have pain. It goes up and down, up and down, up and down. And then they have surgery. And unless it's the smallest surgery, their pain goes up and then comes back down. And this area under the curve, this area is the key. This is the cost of surgery. This is one of the reasons why people are terrified of spine surgery, because they know that this area under this curve is very, very large and can stretch for a very long period of time. So what if we could reduce that curve to something more like background noise, right? What if you could take people through surgery and not have it be so traumatic? That would be a major, major advance in terms of how we're viewed. So this shows us injecting Xpearl. So here we are doing percutaneous pedicle screws, and you'll see that we're doing this under X-ray control, and we're going to inject before we put the screws in, before we do anything else. There's already a screw in on the other side. And so what we do is we inject this under pressure. Now, I'm going to go back to the organic chemistry and explain why this is. A, you don't want the drug to go anywhere near the nervous system because it's lipophilic, right? B, it doesn't diffuse. It stays where you inject it, and that's very important. Now, when we do this in our procedures, we have a very, very different effect. And if I could have the audio guys, do you have the audio on, the volume on the videos back there? AV guys in the back? Do you have the audio on? So here I am 15 minutes after surgery. Can you tell me how you feel?
I feel okay.
Do you have much pain?
Not yet.
Okay. Any pain in your legs or back?
Nope.
Nausea?
No.
Okay. And I see you're drinking something. You're having some
ice chips.
Ice chips. Excellent. Okay.
I asked for a cheeseburger, but they gave me ice chips.
Okay. Great. Okay. Thank you. That's 15 minutes after a spinal fusion. Okay. Now, I know my experience is that when I operate on someone and do a fusion, when I come to the recovery room 15 minutes afterwards, they either are completely asleep or they want to hit me because they're in so much pain. There's no other option. Now, this is the same patient the next day. He's post-op day 1. He had surgery finished about 6 o'clock last night, so he's about 14 hours out from surgery. How are you feeling? Tell us about the pain control.
Yeah, pain, I'm feeling very good. I'm sitting up. I was up last night walking a little. Pain is not really much at all. I've taken no pain medication since immediately coming out of a surgery and haven't needed any pain medication this morning yet. So I'm feeling good and hoping to get home today.
Great, so that's unheard of. In my practice, for someone to consume 0 narcotic medicines, not everybody's like this. About 80% of people are like this. It's really unbelievable. And if you look at our data in terms of morphine equivalents, here you can see again the error bars, right? We can see that there's big changes in the amount of morphine consumed with that. Now, people go, well, wait a minute, that's expensive, right? You have to buy this drug, right? And in Brazil, money's tight, right? So I always wonder about this in new technology, and I'm an Asian person, so I'm very nerdy, and I like computers, and I like technical stuff. And people say, well, this is this computer back when I was a kid versus this computer that everybody uses today. Which one do you think is more expensive? Well, this one's more expensive. This one cost more when it came out. When I look at new technology, I'm not just saying just spend more money. Do you want to have the new technology? Do you want to have the ability to do things better or not? It's very easy to look at any one thing in your hospital and say, this is too expensive or that's too expensive. The point is, are you making things better for your patients? And even when we use this drug, even with the added cost, we are saving money all the time. And this can be used for big surgeries. But the key is you have to inject it where it's going to stay, because where you inject it, it stays because it's lipophilic. And this is actually the original patent on the micelle. This is from the company that makes it. You can see it starts out very well organized like this with the drug in the inside. And over time, the drug comes out as the micelles break down. And you can remember this from organic chemistry, how this might actually work. And this actually shows the pharmacokinetics of these drugs as they're released over time. Now, for the smart people in the room, they'd be like, wow, can't we use this for chemotherapy? Can't we use this for other kinds of drugs? Of course. But of course, we're just talking about pain control right now. And I don't want to go into the details of how you do it, but you have to inject it repeatedly. So we, of course, have our residents or our fellows do this because the attendings are too busy. But we'll inject multiple times. It's not like using the typical local anesthetic. You need to inject exactly where you want the drug to go to create a field block. And I'm going to skip over this video in the interest of time. So I talked yesterday about the ERAS version 1.0. The key was this, the Xpearl, the IV Tylenol, and our medical student. And let me just go through that and what that meant. Again, the difference in hospital length of stay was 1 day. This is the difference in the VAS pain score, better pain control, but not a ton better. And that's good because we're right at the right level of pain. And this is medication consumption, a lot less. Ambulation, people are walking more. And most importantly, in the first 6 months, we're saving over $5,000 per patient for a fusion because we're able to get them up and out of the hospital without complications. So this is really a key aspect. So I would encourage you to think seriously about these aspects of how you manage postoperative pain, right? What are your challenges? What are your challenges in getting new technologies in? How are you going to confront this opiate epidemic, which I understand now is coming to Brazil? And then, of course, the tips and trips that you've heard all morning about the multimodality pain control. So thank you again. Thank you, Asrabal and Dr. Patella. Congratulations on your chairmanship.